Okay, so hello. Thank you very much for having me along. My name is Mike Farquhar. I'm a consultant in sleep medicine at Evelina at London Children's Hospital. As I was saying to Andrew before we started, my clinical work is all with children and young people. But I've been a consultant for coming up for 11 years. And in the space of that time, one of the things I've tried to do is talk about the impact of sleep deprivation and fatigue on how people work in the NHS. That's a piece of work that originally started thinking about people who work predominantly at night. But actually, as that project has gone on, as the work has gone on, it has very much expanded to look at the impact on the NHS as a whole. As I said, I'm a sleep physician, and I usually start you can stick thumbs up or thumbs down in the chat, depending. So thumbs up if you usually get enough sleep, do you think? I'm used to doing this talk in front of big audiences of lots of people, and not many people usually stick their hands up. I am reasonably confident whenever I'm talking to big groups of people that significant numbers will say that they don't get enough sleep. And the reason I can be reasonably confident about that is that we know that when we look at sleep across adults as a whole in countries like the UK, actually most people don't get enough sleep. As an adult, you should be getting somewhere around 7 to 8 hours of sleep on average per night. Everybody's a little bit different, but 7 to 8 hours is about the average sleep requirement for adults. We know from big surveys, beginning to get data from things like Fitbits and all the rest of it, that the amount of sleep that people typically get is probably closer to 6 to 7 hours. Now, that doesn't sound very much. You're missing an hour of sleep each night. You can have a double espresso, sort it all out, everything's fine. But if you think about that in a slightly different way, if you were missing an hour of sleep every single night of your life, over the course of a week, you will miss the equivalent of an entire night's sleep. And that's before we even start thinking about plugging you into rotas and environments that are going to affect your sleep and make that even worse. So I can be reasonably confident that you are already a group who are probably a little bit sleep deprived, because we know that most adults are. So you are probably sleep deprived already, even before you ventured anywhere near the NHS. Why does that matter? What is the reason for sleep? This is one of these things that people sometimes say, oh, well, nobody knows what sleep is for. We're actually beginning to get a really good understanding of what sleep is about. As the cartoon at the top says, we spend a third of our lives asleep, pretty much. And we don't evolve to do something like that unless there's a really good reason for it. Our understanding of sleep and exactly what it does for us is constantly expanding. It's one of the reasons I love being a sleep physician, is because we don't know all the answers and we're constantly learning new things. But a really simple way to think about sleep and why it's so important is to think of your brain and body as if they're a complex piece of machinery, like a car. You will know that if you have a car, you need to think a little bit about repair and maintenance. You need to take it in for its MOT, make sure everything's running, do all the bits that keep it running smoothly. And I'm sure you will know that if you skip that repair and maintenance, problems tend to get more problematic, they're more expensive to fix, they're more of a big deal. So that regular repair and maintenance is essential to keep a complex piece of machinery like a car running smoothly and efficiently and effectively. Your brain and body are exactly the same. They are a complex piece of biological machinery, and just like a car, they need regular repair and maintenance to continue functioning at their absolute best. And this is what sleep is doing for you every single night of your life. It is making sure that your brain and your body are being tuned up, fixed up, so that you're able to carry on working at their absolute best. And just like with a car, if you skip on sleep, you will carry on running for a little while. But the more sleep you miss, the longer that goes on, the more problems are likely to accrue and the more complex and complicated to sort they are likely to become. So sleep plays this essential repair and maintenance role. There's a few simple bits of sleep biology, or relatively simple bits of sleep biology, that tie into all of this, particularly when we start thinking about night work. And hopefully at some point in your lives, you've all been lucky enough to have traveled far enough around the world to become jet lagged. Most people are familiar with the concept of jet lag. It's that really uncomfortable kind of feeling when you're out of sync with the world, where your internal clock is telling you it's midday, the world is telling you it's midnight, and nothing seems to work right. We don't think straight when we're jet lagged. We feel all out of sorts. We get aches, pains, nausea, all sorts of things are not right when we're jet lagged. And it takes a little bit of time for us to resynchronize when we've been on holiday, particularly if we go far enough around the world to Sydney or New Zealand, places the other side of the world, for our clocks to resynchronize and get back into sync with how the clock is running where we've gone on holiday or to live or work. Why does that happen? There is a concept called our body clock or circadian drive. I will take you through this graph, don't worry. It looks a little bit scary at first glance, but it's not too bad. The orange line in the middle represents your level of wakefulness or alertfulness over the course of a day. And most of us are reasonably alert through the day, and around about this time of day, we start to get a bit sleepier and begin to think about heading off to bed. There are two broad concepts that contribute to how we feel in terms of alertfulness and wakefulness at any particular time of the day. Along the top of this graph, the arrows pointing down represent what we call sleep load or sleep pressure. You can think about this as a bit like hunger, but for sleep. The more you have been awake, the more you build up a need to be asleep. And that builds up pretty linearly as the day goes on. So the longer you've been awake, the more sleepy you get, the more sleep pressure you have, the more you need sleep. Most of us, however, do not feel increasingly sleepy with every passing minute of the day. We maintain a level of wakefulness that is reasonably consistent throughout the daytime. And the reason for that is countering that sleep pressure along the bottom of this graph is what we call the circadian alerting signal. You can think of this as being a bit like Red Bull from your brain. It's basically just a signal from your brain to keep you awake. And at the beginning of the day, that signal doesn't need to be particularly strong because the sleep pressure, hopefully you've had a good night's sleep the night before, the sleep pressure is still relatively low. The alerting signal doesn't need to be particularly high to match it. But as the sleep pressure builds up, so too does the alerting signal, keeping you going to keep you at a level of alertfulness and wakefulness that is relatively even. You will all, I'm sure, be familiar with that dip around about the middle of the day when we all tend to feel a little bit more sleepy just after lunchtime. The reason for that is the alerting signal doesn't quite keep pace with the sleep pressure building up. So in the tug of war between sleep pressure and being awake, sleep pressure is winning. And we think that's because when we think back to when we evolved back in the plains of Africa, it made good sense not to be out in the midday sun. So we had this kind of protective mechanism that would take us off and have a little snooze in the middle of the day. But as the day goes on, that alerting signal really ramps up. And actually at this time of night, your alerting signal is pretty much in overdrive because it's trying to keep you awake until it gets towards bedtime. So right now, your alerting signal is really strong to counter that sleep pressure. Over the next few hours, the alerting signal will drop off, the sleep pressure is unopposed, and that's one of the things that helps you to get off to sleep. And this complex interaction between these things is what explains the level of alertfulness and wakefulness that we have at any particular time of the day. Normally, we cycle 24 hours, everything is fine, we wake, we sleep, we wake, we sleep, everything is fine, everything is rosy. The problem is, and this is, as I said, this piece of work started thinking about night shift. Once you start thinking about things like night shift and jet lag, those signals become unsynchronized from what we're expecting to do. If you look back on this graph at 3 o'clock in the morning, that alerting signal is pretty much zero. There is no help coming from your brain to keep you awake at 3 o'clock in the morning because your brain thinks you should be asleep, quite rightly, at 3 o'clock in the morning. If we then plug you into a rota where you have to work around the clock, where you have to do shift work, you are not going to be in a position where you're getting any help from that. Every cell in your brain and body is telling you you're meant to be asleep. And the symptoms of that, how that makes you feel, is very similar to jet lag. And that is a really basic, simple point. Working at night is like working when jet lagged. And we probably wouldn't expect somebody to get off a plane from Sydney and expect them to suddenly go and be a paramedic on duty or a nurse on an intensive care ward. We would give them time to adapt and resynchronize themselves to get them into the right frame of mind, the right frame of body to be able to do that. But that's not what we do when we think about night shift. Working at night is a phenomenally biologically unnatural thing to ask anyone to do. And historically in the NHS, we've basically just plugged people into these rotas and expect them to get onto it without acknowledging that this is a really, really difficult thing for anyone to do from a biological perspective. So reframing it like this, working at night is like working with jet lag, is a really simple way to get that point across. I boil lots of things down to really quite simple concepts like that, because when you're trying to persuade people to change how they think about things, the simpler you make the idea, the more persuasive it often is to make people think about it differently. We then need to think about the consequence of that. Don't worry about all of the words on this particularly. This is a systematic review from the BMJ from a few years ago, looking at the consequences of what happens when people work shifts in particular. And what it boils down to is this. I said earlier that we are getting an increasing understanding of all the reasons why sleep is important. And a lot of that understanding comes from looking at what happens when people don't get the right amount of sleep and are sleep deprived. And I'm afraid a lot of that data comes from people who work shifts because they are a group of people who are inherently sleep deprived and have all the complications of working against their body clocks. And the kind of things that this will do for you, I'm afraid, is it will increase your risk of cardiovascular disease, it will increase your risk of some types of cancer, increases your risk of obesity, increases your risk of developing type 2 diabetes, increases your risk of Alzheimer's disease. Working around the clock is not good for you. And we can't take that away. We have to work around the clock to be able to do the jobs that we're all here to do. The NHS is a 24-hour organisation. We have to be. But what I think we should be doing is acknowledging much more that when we ask people to work around the clock, that is something that has a personal biological cost for them. And we should be doing everything we can to mitigate that and support it, rather than just putting people into rotas and expecting them to crack on and get on with it. One of the other things it does, by the way, is working around the clock very much affects your appetite and hunger. It will probably not surprise any of you who have worked night shifts to learn that on average, a person who's just done a night shift will be 14% hungrier than someone who has not. And that becomes part of the problem, because it means that people who have worked shifts are out of sync, eat more, put on weight, and that leads to many of these secondary problems developing as it goes along. It's not just the cost to you, though. There is also a real and significant cost to patients, potentially. You are there to provide acute and emergency care. By definition, if you're there at night, anything that we are doing actively is going to be for those patients that need it the most. This is data looking at junior doctors in intensive care unit down in Southampton, looking at their ability to assess risk. And I won't go into the details of the experiment just because we're a bit short for time, but what it basically shows is that the more sleep deprived you are, the more risky decisions you are likely to make, but your level of confidence in those decisions remains the same. So the more fatigued you are, the riskier the decisions you're likely to make, but your ability to understand that you are making a riskier decision is in itself impaired. So you're much more confidently likely to make a mistake or do something that is going to cause harm than if you are appropriately rested and not fatigued and tired. So fatigue increases risky decision making. That boils down to really, again, basic, simple points. Tired doctors, tired nurses, tired paramedics, tired anyone is more likely to make a mistake. And in an organisation like the NHS, when we make mistakes, the consequences can be really significant. So we should be really thinking about all of the ways that contribute to this tiredness, the impact of fatigue, and thinking about how we can reduce it, because it has a cost for us and it has a cost for our patients. The longer we've done this work, as I said, we began looking at night shifts because that's a very obvious target for thinking about sleep, sleep deprivation, fatigue. But actually, the longer we've done this work, the more that we've become aware again, and this is not rocket science, it's not going to be a surprise to any of you. Fatigue is not just a problem that affects people who work at night or as they work through the night. This is data. I apologize. A lot of the data that comes from this is from doctors. And the main reason for that is that we're just a bit better about getting doctors to answer questions and ask questions. The data is the same when you look at it in different groups, but a lot of the bigger number data comes from doctors. So although it's doctor data, it is very generally applicable no matter what profession you're working within the NHS. This basically was a question that asked them if they felt fatigued during their normal working day. And about 20% of doctors say that they regularly feel tired in the daytime sufficiently that it impacts their ability to do their job. So fatigue is not just a night shift problem, it is an NHS problem in the way that we work. We know from other professions that when we look at risk of accidents in other industries, if you work shifts that are longer than 8 hours, your risk of having an accident increases. More importantly than that, given that many NHS workers still work 12, 13-hour shifts, when you look at what happens between 8 and 12 hours of work, that risk doubles again. So your risk of making a mistake or having an accident, of something going wrong just because of fatigue, significantly increases in the type of shift patterns that we tend to still see within the NHS. That can then be summarized by thinking about that in a slightly different way. This is the performance curve. This is much loved by athletes, sports medicine. If you talk to athletes in training, they will tell you that there is an optimal amount of training for them to do. And if they overdo it, then actually their performance drops down. So along the bottom of this graph, you can think about it as stress or pressure, and along the y-axis is performance. So what you're putting in, what you're getting out. And no matter what you look at, we know that there is this optimal zone that circles up around the top of this curve, where people are functioning at their best. But actually, if you push beyond that, if you keep piling on the pressure, if you keep pushing people, their performance drops off, and it can drop off quite quickly. And it's often much more difficult to recover it and get it back to that optimal point. And athletes spend a lot of time making sure that they stay at that top end of the performance curve and not falling down the side. If we think about this in the context of an organisation like the NHS, what that means is that if we just continue pressuring people to keep going, work through the fatigue, carry on doing everything, then actually they become less effective, less efficient, they're more likely to make mistakes, they're likely to be consequences within a shift. But when we start modeling that over their careers, it means they're also much more likely to have the consequences of that. So stress, ill health, and as you can see at the side, breakdown, burnout. We should be doing everything we can in the NHS to make sure that people are functioning at the top of this curve and not pushing them over to the side. But unfortunately, a lot of the time, the culture in the NHS is often very much still go, 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 without thinking about how to stop and pause frequently to make sure that we keep people functioning at their best. I spoke earlier about some of the consequences of this. The reason that I did this work at the very beginning is because I was a junior doctor. I did all this, I did all the shift work and saw the impacts of it. And I saw the consequences on my friends and colleagues. And in particular, I knew stories from my friends and colleagues about the risks of driving home after a night shift. We have had a huge culture change over the course of my lifetime about drink driving in this country. And this is kind of the attitude that we see now, you know, that there's this very clear messaging that alcohol and driving just do not go together. I grew up in the Highlands of Scotland in the 80s, and the attitude to drink driving in Scotland and the rest of the UK, I think, in the 80s was pretty much this. It was kind of like, you know, as long as you're not absolutely paralytic, you know, 5 pints might be pushing it slightly, but you're probably okay if you've had a few more pints to get behind the wheel of the car. That was very much the attitude I remember when I was growing up to drink driving. But that has very much changed. And we now have this kind of zero tolerance attitude, generally speaking, to alcohol and driving. The reason for that, as I'm sure you know, is that even a small amount of alcohol can impair your reaction time in particular, which means that if you have to respond quickly to something on the road, then your ability to do so is impaired. And at speed, even small impairments in things like reaction time can have a big consequence. So that's why we set the limits in terms of driving to make sure that that impact is as low as it possibly can be. What we don't talk about nearly as often or as much, though, is that fatigue and tiredness impairs your reaction time in just the same way as alcohol does. If you have been functionally awake for about 16 to 18 hours, your reaction time will be impaired to the same degree as if you're at the legal drink drive limit in terms of alcohol. And most of the time these days, people will stop, you know, if you've had a glass of wine or half a pint of beer, or whatever, they'll stop and think about whether they're going to get behind the wheel of a car, whether they're safe. That people don't think about tiredness and fatigue in the same way, to the same degree. And I think people are much more likely still to get behind the wheel of a car if they're tired than if they'd had alcohol, even though actually they are impaired just as much, if not more, by fatigue when they're driving. And in exactly the same way that even a small amount of alcohol can have a big impact, so too can tiredness and fatigue. Oh, sorry, that slide's got a bit wrong. Driving tired is like driving drunk is what that should say. And again, that's one of these really basic, simple points that we tend to try to make about the impact of these things in terms of getting the points across. And that's a way that I think we don't think enough about when we are talking about fatigue and tiredness. This can result in the most devastating of consequences. And this is why I started doing this work a decade or so ago. Every 6 months or so in this country, there will be a story in a local newspaper. It very rarely makes the national news, of a doctor, a nurse, a paramedic, somebody driving home after a night shift who crashes and dies because they have momentarily fallen asleep or lost control of their car as they're driving home, and they suffer the ultimate consequence. This is one of the risks associated with night shift working in particular, but fatigue in general. We probably can't reduce this risk to zero, but I think we absolutely should be making sure that people are aware of these risks, and we should be building in as much as possible protections to make sure that these kind of things are much less likely to happen. I say every 6 months or so on average, I see one of these stories popping up, and every single time it's what could we have done to try and reduce the risk of this and make it less. And that's why I started doing this work at the beginning. So with all of that in mind, as I said, when I started as a consultant, I tried to think about how we were going to change it. I said, look, let's stop, let's look, how can we practically try and make changes that might make a difference for people in terms of doing it. One of the problems is that no matter what your profession, I'm willing to bet that you've had very little teaching or training about sleep and sleep deprivation in general. A third of your life is sleep. In medical school curriculums, on average, there is less than an hour of teaching about sleep over the course of 5 years of medical school, and other professions are very similar. We don't talk to you enough about sleep and why it's important for people to be able to think about the impact and manage it for themselves. When I became a consultant, we introduced for our junior doctors initially, we've now expanded it to other staff groups, teaching, which aims to give them the basic information about sleep, to be able to manage and optimize their own sleep, to try and make them be a little bit less sleep deprived, improve the quality of their sleep, and to give them some tips about working through the night shift that might help to try and mitigate this. Now, I'm not going to go into the details of how to do that. I know that people are probably interested in that, but what I'll do at the end is I've got a paper that links to all of the detail of that if you're interested in what you can do to try and think about improving sleep from the perspective of shift work in particular. But it's all really basic, simple stuff. It's how to optimize your bedroom environment for sleep. So particularly if you're a night shift worker and you're in the summer, things like blackout curtains and blinds can make a big difference. Things like eye masks, earplugs can make a big difference. There are strategies about how to work through the night. So we talk to people about how to use caffeine in a sensible way to try and help manage night shift related tiredness, and not in a way that's then going to screw up the sleep you're trying to get when you're sleeping in the daytime. We talk to people about getting home and little simple things. So Paul's here wearing sunglasses because sticking a pair of sunglasses when you step out into daylight after a night shift just blocks the impact of light on your brain a little bit. Light is basically something that's telling you you're meant to be awake. The more light there is, the more likely you are to be awake. Blocking out the light just makes it a little bit more likely you can trick your brain into getting to sleep when you go home after a night shift. And there's lots of other hints and tips like that. And then we talk to them about how to recover after night shifts, to get back into day shift mode, to try and get them reorientated and reset their clock back again. That teaching takes about an hour in total to go through it in detail. And we've been doing it for several years now. We've been back and we've looked at the experience of our trainees, our colleagues who've done that. And about 3/4 of them say that they've changed either their core sleep habits or their approach to how they work at night in a way that they think has helped to make working nights a little bit easier for them. It hasn't transformed it so suddenly night shift is this paradise that they all love doing and all the rest of it, but it has made it a little bit better. And thinking about how you as individuals can improve your sleep or how you approach things is one part of the approach to this. However, and there's a really, really, really big but about this, this is the smallest part. Asking you to make changes to improve the impact on you of what we are asking you to do, to work around the clock, to provide that 24-hour care, is the smallest part of this. This is a systemic problem, and there has to be systemic solutions. You will often hear, Andrew mentioned at the beginning as well, I always laugh when the word comes up. You often hear this concept of resilience, and I think a lot of people have a very ambivalent reaction to the word resilience. So there is a lot of value in resilience. Me teaching people about sleep and sleep patterns is resilience training. But a lot of the time in the NHS, people approach resilience with this kind of attitude that they're basically being told that they just have to toughen up, sort themselves out. The problem is you, be a bit more resilient and just cope, which is not really a very healthy way to approach problems like this. So resilience often comes across with this kind of two-edged feel to it. That is something that then gets amplified. We saw this very much during the pandemic. If you can remember back to the dim and distant days when people were banging pots and pans in praise of all our hard work. But we gave people the impression that NHS staff were superhuman. There was a lot of this in the pandemic, how amazing we all were, how superhuman we are, how brilliant it was that we were able to do it. And that feels great in the moment. You get that validation of, yeah, people recognize how much work I'm putting in, how great I am. But the problem is this very quickly becomes a double-edged sword. This becomes the standard that we hold ourselves to. We think that somehow we are better and better able to cope than other people. I apologize, the formatting on these slides I think has gone slightly weird. The next slide is another one. So what this says is NHS staff are not superhuman. And that is a really, really important point. I think a lot of the time we very much give ourselves this impression that somehow we are better able to cope. I'm afraid your physiology is just as boringly normal as your patient's physiology, but you don't give yourself the permission. You always feel that you should be the ones that are able to keep going. And it often gets reinforced by these kind of attitudes that we saw during the pandemic and after and beyond. We used to give out from our trust, I work for guys in St Thomas's in London. When I started work, the nursing staff used to get given a tote bag that said, "What's your superpower?" Mine's I'm a GSTT nurse. And everybody loved them. They thought, this is great, you know, I'm being recognized. You know, how amazing I am and the work that I do. But if you flip that around, if you are not superhuman, you're not good enough to be a GSTT nurse. And as soon as you flip it around like that, you can see how toxic this idea can become. So you're not superhuman. You shouldn't be trying to hold yourself to impossible standards. But a lot of the time we do. And that means that resilience is only ever part of the solution. Resilience in this context is looking at those things you can do as individuals to try and make this better. But that is an important part of the solution, but it's the smaller part of the solution. And the flip side of that has to be thinking about the systemic approach. Why is that important? I alluded to it earlier on. We work in an NHS that is under a huge degree of pressure, is significantly under-resourced to do the task that we are all here to do. And we know that that has this really, really significant consequence for many of our colleagues in terms of burnout. We see people leaving the professions. We see people getting stressed, becoming ill as a consequence of constantly trying to fill in the gap between what our patients need and the resources we have. And all too often that missing gap is filled from us. We are exhausting ourselves to fill the missing gap, and that leads to burnout as a problem. Again, this is doctor data, I apologize, but partly through work that the group that I'm involved with that does this, there's a survey every year that looks at the experience of doctors in training that they all have to fill in. And a few years back, we incorporated questions about fatigue and burnout in particular into that, so we could start to try to track this kind of data. It's quite superficial, the kind of questions, it's not an in-depth assessment of burnout, but they're a useful way to track. And all of the indicators for burnout are generally increasing. There's this interesting drop rather in the pandemic year, when actually, although it was very stressful and very pressured, we were also quite supported in many ways. People, I think, came together in a way that helped people to feel better about what they were doing. But as you can see, it very quickly flipped back. And this year's data, again, continues to show increases in these measures. We have very high levels of burnout markers in the healthcare professions, in the NHS in general. When we boil that down, this is splitting the data into trainees and trainers who also fill in this survey. The light blue and orange towards the left-hand side of these bars are people who are assessed as being at high or moderate risk of burnout. 62% of medical trainees in the UK are currently felt to be at high or moderate risk of burnout, and 52% of the more senior doctors who train them. Those figures are replicated across the other professions. I say the data happens to come from doctors in this case, but the doctors are not special or unique in this. A lot of the work that we've done was working with anaesthetic organisations, and they've got a lot of good data that shows the impact of all of these types of things on their teams. When we look at anaesthetists in general, they're actually in the lower risk of burnout. So we know that this group, who are at a lower risk of burnout, have lots of problems associated with fatigue. I can be pretty confident that that means when we start looking at specialties like emergency medicine at the top there, where the assessed risk is much higher, that these problems are even more acute. So what can we do about it? A lot of it is about changing the culture, about really basic, simple stuff. We work in an NHS where the attitude at the moment is very much do more with less. We don't have the resources to do what needs to be done, and we're all encouraged to do 105%, do that little bit more to get things done. The problem with that is that we are not 105%, we're all 100% at most. And actually, if you think back to the performance curve, if you push yourself to work at 100% all the time, then actually that's not sustainable. So this kind of attitude that often we are forcing ourselves to keep going is one that is very prevalent. And really simple concepts become really important. These road signs, you see them up and down roads across the country. This one is from the A9 in the north of Scotland, where I'm from. So it's a beautiful road, very scenic. But lorry drivers who drive it all the time to get bored of the scenery, they keep driving, they fall asleep behind the wheel of their cars, they cause accidents. So they stuck these signs up to remind them tiredness can kill, take a break. And that concept absolutely applies. If you think back to that performance curve, taking a break is what you need to do to keep yourself functioning at the top end of that curve rather than dropping down the side. A few years back, we introduced into our trust this kind of concept that breaks are not a luxury, they're not optional. They are an essential part of the care that we deliver. And actually, if any member of our staff gets to the end of a 12-hour shift and they've not had a break, well, actually, that's an issue that we really need to think about. Why? Because that probably means they're not delivering the most safe, the most effective, the most efficient care if they've worked all the way through a 12-hour shift without any break at all. So trying to encourage people to rethink about this. A break is something that too often we see as a luxury. It's you get to the end of a shift and it's like, oh, I got a break today. That was a nice bonus. It's not a bonus. It's essential. If you're not getting the breaks, you're not capable of delivering care to the standards that we should be aspiring to for ourselves and our patients. This is a really difficult concept to get across to people. People constantly push themselves and will always find excuses not to. We tend to be, as professionals, we tend to prioritize our patients before ourselves. And sometimes actually the best thing for our patients is for us to go and have a cup of tea and a Kit Kat and come back and deal with our patients when we are more rested, as long as they're not actually arresting or anything right in front of you. There are other things that we need to think about. I apologize, the next slide is not going to work either. This is the junior doctor's contract from a few years ago, which you may recall was a bit controversial at the time, and still is. But it was a negotiated contract, and you can see the principle 1 there, which is the important point. Contractual limits on working hours and protected rest periods as set out in the schedule are necessary to ensure both patient safety and the safety of the doctor. And again, this is the doctor's contract, so doctor here, but this applies to any healthcare professional. Your breaks, your protected rest, your working hour limits are essential for patient safety as well as your safety. And that's the thing you need to keep with you when you are thinking, should I take this break? Yes, you should, because these are the concepts that are underpinned by that. We've done a lot of work with various organisations over the last few years to try and get this in. So the British Medical Association introduced something called their Fatigue and Facilities Charter that looked at what organisations should be putting in place to support these concepts, both in terms of how they staff rotas, but also just the facilities, what should be available to support staff. We've done a lot of work with the anaesthetic colleges who have thought particularly about theatre environments, about how they can do that. But a lot of the resources they produced are very applicable across the board, and I commend them to you. They've got lots of really practical ways to think about how these can be put into place. So there's a lot of work that's been going on. When I first started as a medical student, one of the very first things I was told to read was this book. It's a novel called The House of God, and it talks about the experience of junior doctors in America in the 70s. So American doctors, quite different, 70s, quite a long time ago. But actually their experience was not too dissimilar. It was a lot of stress, a lot of pressure, a lot of overwork, a lot of fatigue. One of the characters in that book says this: how can we care for patients if nobody cares for us? And that's a concept that I think we often forget. We're a really important part of the equation in terms of patient care. But a lot of the time we don't think about prioritizing ourselves, about looking after ourselves to be able to look after patient care. If our focus is patient care, then actually part of that has to be about how we protect ourselves. And this is a concept I think that got missed out of NHS thinking for a very long time. It's beginning to come back in. So this was published in 2019 from NHS, what was then Health Education England. It's now been absorbed into NHS England, I think. But this was looking at the factors that affect the mental health and well-being of NHS staff. And one of the things they said was exactly the same as that novel. Who cares for the people? Who cares for the nation's health? And they really emphasised that we have to think about how we look after ourselves and our colleagues if we are going to be focused on how we deliver best care for our patients. The GMC at the end of 2019 had commissioned this. It was looking at medical students and doctors again. Michael West and Denise Coy did a really in-depth analysis of all of the factors that affect doctors and medical students in terms of their health and well-being. And Michael's top-level summary was this: we can't simply go on the way we are, loading more responsibility onto doctors already struggling to cope. Where workloads are excessive, patient care suffers. And again, there's nothing special about doctors in this quote. This could be any other group of professionals within the NHS. You will see that was November 2019. That was just before we were introduced to COVID. So at the end of 2019, I was kind of feeling quite confident that we were in this position where actually people were beginning to think about things. We were going to do things differently. It was all going to be heading in the right direction. And then COVID came along and slightly, threw that out the window a bit. But this is still true, and it's more true now than it was 4 years ago. Oh God, 4 years ago, that's quite scary, isn't it? Their report made a number of recommendations, and because people like me were involved in it, they really emphasised the importance of things like rest and sleep, but also when we design, I apologise to go off the side as well, when we design rota patterns, we have to have rota patterns that make sense when we think about that body clock biology that I was talking about at the beginning. So to sum up, what can we do to think about this? The issue of sleep deprivation, and fatigue. So something that started as a fairly focused piece of work about how do we support people who are working at night, as you can see, has grown quite a lot to think about the impact of fatigue, which is a much more broad concept. And it's really difficult. Making change in an organization like the NHS is really challenging. Even something as simple as persuading people that taking breaks is the right thing to do is often quite a difficult task. I think we need to continue to work with the top level, the colleges, to try and make sure that these kind of conversations are happening, that people are making sure that the underlying points, that this is a systemic problem and it needs to have systemic solutions, are being talked about at the highest levels. At the ground level, I think every single member of NHS staff who starts work in the NHS should be given teaching about their own health when working shifts and nights. So anyone who works nights in particular, but anyone I think in a frontline position should be given some teaching and education about sleep deprivation and fatigue, because you need to be armed with that knowledge to be able to make the best improvement. When I started doing this teaching, the more junior the doctors were, the more enthusiastic they were. This is amazing, you've taught me something. All the more senior doctors said, yeah, we know all this, but it probably took us 6 or 7 years of working shifts to work all this stuff out for ourselves. We shouldn't be asking you to work it out for yourselves. We should be teaching you it right from the very beginning to make sure that you have the best chance of mitigating all of the things that we've been talking about. And we should be doing things like having conversations with employers about the simple things, about making sure that people understand that breaks are not luxuries, they're essential, how we build that in, which is really challenging in an NHS at the moment where the messaging is very much do more with less. We have to really be thinking about what that means. Do more with less means people are just pushing themselves to the limits all the time, and that has consequences. We have to look to the long game. If we want people to stay in the organization, to keep working, we have to care for them and protect them, and that means getting these really basic points right. Resilience kind of morphed into well-being during the course of the pandemic, and there was lots of really good work that was done under the badge of well-being. But I think we need to be really honest. I'm sure our trust was not the only one where staff well-being at some points became, here's your £5 voucher for the coffee at Marks and Spencer's, or have a yoga lesson in your lunch break kind of thing. And these things can be great. I'm not knocking them particularly, but they're not making fundamental change. When we are being honest about concepts like staff well-being, again, it's about getting the really basic, simple things right. People don't want free yoga lessons. They want access to decent food when they're on nights. They want a locker. They want showers that work. All these really basic, simple things are what actually matter to people's experience. And getting those right is much more important for many people than the kind of token gestures. We had a prime minister, 2 prime ministers ago, Boris Johnson, who said he didn't believe in gesture politics. The ultimate example of gesture politics was if you work in the NHS, I don't know if you know this or not, but a few years ago, the Queen gave us all the George Cross for our hard work. This is gesture politics at its highest level. This means that's lovely, but it means nothing. I would much rather have proper staffing than the George Cross, but we've all got the George Cross for what that's worth. So when we think about well-being, it has to be meaningful. It cannot just be simple gestures. It has to actually make differences for people on the ground. There is going to be a role for fatigue risk management systems. These are the kind of technologies that we see in industry. So airline pilots, train drivers, long distance drivers, oil rigs, they all use technology to be able to assess fatigue and warn when people are getting to a point that their fatigue might make them unsafe. The NHS is not a safe place to think about using these at the moment. And the reason for that is a lot of the time, the blame, if something goes wrong, if you have identified that you are fatigued and then something goes wrong, we have a blame culture in the NHS that probably makes you more vulnerable. So if you're a pilot and you ring high on the fatigue, you will get taken off duty and another pilot will fly your flights that day. In the NHS, we barely have the staff to staff the rotas we've got. If you do a test that says you're too fatigued to work, chances are you're not going to get off that shift. And if you work when you've proven that you're fatigued and something goes wrong, I think that makes you more vulnerable. So I absolutely think there is a role for fatigue risk management systems within an organisation like the NHS, but we have to think about how they're embedded in NHS culture in a safe way so that they don't actually make staff more vulnerable rather than helping to protect them and their patients. This man again, so whilst he was in the relative wilderness, so between his time as Health Secretary and Chancellor of the Exchequer, Mr. Hunt was chair of the Health and Social Care Committee. And just before he became Chancellor of the Exchequer, the Health and Social Care Committee published a report that looked at NHS staffing. It's interesting, Mr. Hunt, when he was Health Secretary and when he's Chancellor, takes a very different view to the NHS than he does when he's on the outside looking in at it. He published a report that said it is clear that workforce planning in the NHS has been led by the funding envelope available, so how much money there is, rather than by demand and the capacity required to service that demand. What he was acknowledging was that there aren't enough staff. The demand is higher than the money that is there to pay for the staff to do it. And you are the ones filling that gap every single working day. Again, data from doctors analysed and anticipated that the average doctor in the NHS is probably doing about 120% equivalent of a whole-time employee. And again, I'm pretty sure that's true of anyone in the NHS. We're all working in overdrive all the time. And this is why the NHS has been chronically underfunded, as acknowledged by Mr. Hunt, for the last decade. And there just aren't enough resources in the system to do the job that we are here to do. This is a similar report, came out last year, looking at the impact of staffing shortages in maternity and neonatal care. Staff are working flat out, doing their best to deliver care. They are stretched to the limit. It is leaving them burnt out. Again, this is not news to you. You all know this. You live it every day, I suspect. But these are the reports that are coming out. And again, the co-chair of this group was Mr. Hunt. So he's very happy to acknowledge these things when he's not having to be the one paying for it or dealing with it. Again, a year or so ago, the Academy of Royal Colleges came together and said that we need to stop normalising the unacceptable. And normalising the unacceptable in this context is that concept that we're all working at 110, 120%, whatever it is, all the time. And we've just normalised that. We think that's how things should be. We've forgotten that actually we should be able to stop and take breaks. And there should be quiet times. There should be points where we can down time a little bit, recharge our batteries. But a lot of the time we're just working flat out because there's not enough of us to do the job. And that means that fundamentally all of this comes down to safe staffing. We do not have enough staff to safely staff rotas. When you start thinking about the impact of fatigue, we need more staff to make sure that we can do this properly, that people get breaks, those really simple concepts again. We just don't have enough people. And until we do, we are never going to be able to put in place all of these principles. So a lot of what I am doing is trying to give people the best chance to work as well as I think we can, and to protect yourselves as well as we can, but acknowledging that it is very much within this very constrained environment that there just aren't enough of us to do it. And that, I'm afraid, very much means that when we start thinking about why people choose to strike, these reasons underpin all of it. We have to make the point that there is no way that we can do this unless something radical changes.